the chairman and the speakers and on behalf of EGROW Foundation. So today webinar's topic is a role of sanitation and but sanitation on child mortality and child malnutrition. Okay, so this webinar will be around 1.5 hour, being chaired by Dr. Virmani, who is currently member of Niti Aayog. He is also our former chairman of EGROW Foundation. So previously, he has also had many positions, including executive director at IMF, then chief economic advisor in Ministry of Finance, advisor in the Planning Commission, and he has many publications and policy briefs. The speaker of today's webinar is Ms. Dr. Sabharwal, sorry, and she is faculty at Shivnadar School. The discussant is Professor Praveen Kumar, head of the Department of Pediatrics, Lady Harding Medical College. So this will go. The webinar will go like this broadly. The chairman will speak around 15 minutes, speaker around 20 minutes, and discussant again around 20 minutes. Then we will have around 20 minutes for the question and answer. So this time slot, for the first time, we are trying at 11 o'clock. Earlier, our webinar used to held in the evenings. So, sir, with this introduction, I will hand over to you to take further.
Thank you, Ratanji. So let's start straight away. So we are talking here about a paper which is titled Child Malnutrition and Mortality, Role of Sanitation Sewage Systems, which is NITI working paper, which was jointly authored by myself and Shruti. Next. So what I will do is I'll talk for about 10 minutes giving the settings, after which Shruti will go into the kind of academic details of the paper, and then I will conclude for about 5 minutes at the end, and then we can have the discussion. So child malnutrition, where child we define as under 5. There are also definitions of under 3, but under 5 is commonly used, remains a public health challenge. Despite free food for 2/3 of the population, child malnutrition persists, and this is defined in terms of stunting, underweight, etc., which Shruti will clearly define subsequently. The thesis of this paper is that poor sanitation and sewage treatment contributes significantly to child health outcomes. And one of the kind of less well known and understood issues is what I call what is called environmental enteric dysfunction. So this is something which has been discovered over the last 30, 40 years in developing countries. It's a chronic gut inflammation due to fecal exposure. That is where the sanitation part of it comes in, and the sewage. EED, for short, reduces nutrient absorption even for well-fed children. That is a critical element of this paper. It's very important to understand this, and leads to growth failure and vulnerability to infection. So let us briefly start with a picture of public health in India, which is relevant to this issue of EED, or environmental enteric dysfunctions. Health, firstly, is a state subject under India's constitution. The focus, I'm talking about the history of India from kind of partition. Focus initially has been on curative rather than preventive care. Limited attention in the beginning, particularly to clean water, sewage, and sanitation, especially we can divide it before 2000 and after 2000. Only in 2002 was the so-called Total Sanitation Campaign launched, and subsequently the Nirmal Bharat Abhiyan in 2012 and the Swachh Bharat Mission in 2014. So it is really where these issues started being recognized as very important was after 2000. And households without toilets, 55% in 2005-6 have come down to around 19% by 1921, according to official data and confirmed data. Open defecation reduced from 40 to 19%. So this is the broad picture of the public health, which is relevant to the paper we are discussing. It's useful to have a model. This model incorporates both the literature on child malnutrition, but also the way we look at it in our estimation in the paper. So you will notice that three squares are very prominent: sanitation, malnutrition, where we are referring to child malnutrition, and mortality. So this is the big theme of this paper and the results, as we will show you. Other issues which have been relevant, if you look above, open defecation, one of these results of our paper will be the mechanism, from sanitation to open defecation to malnutrition. Above the ratio, above this middle column, you will see income, nutrition. People have talked about all these things. We investigate all of them to see what impact they have. And if you look below this middle level, drinking water, diarrhea, government programs affect, general programs, including nutrition, child care, maternity care, we call those government programs here, and female education, which we find is, over the years, people have talked about this as important, and we investigate this also. This gives you a picture. If you look at the left graph, what we have here is we have population using SS private toilets on the left graph, and the shared toilets on the x-axis in the right graph. On the y-axis, you see the percentage of children who are stunted by state. So this is a plot of stunting and underweight according to the percentage of people with toilets on the left. And you can see that both stunting and underweight, and you get similar things for the third measure of malnutrition, that basically declines with the improve in private toilets on the left graph and the shared toilets on the right graph. So the visual picture is very important in my view, because much of the medical fraternity still has, in my view, this is my personal view, still tends to ignore these, even the correlations, and they go by traditional methods, traditional ideas which relate to nutrition and partly to income, despite results which have shown that even higher income children, if they are in an adverse environment of open defecation, etc., are equally affected by this EED, the environmental, and the EED does not respect income. So if you are in an environment, whether you are rich or poor, it does not matter. Okay, so with that broad overview, let me hand it over to Shruti, who will take you, I hope, for 20 minutes through the data, the methodology, and some of the important results.
Thank you, sir. Okay, so as sir said that we're gonna check, in this paper, we're testing the hypothesis that sanitation affects malnutrition. In order to do that, we are using a 2-period panel data of all the 28 Indian states and the Union Territory of J&K. So the data is sourced from NFHS Survey 4, which covers the period 2015 to 16, and NFHS 5, which covers the period 2019 to 21. Now, this variable malnutrition is being indicated by three variables: stunting in children, underweight children, and wasted children. So stunting is measured by less height for age. Underweight children are children who have less weight for their age, and wasted is a ratio of underweight to stunted children. So that would be children who are very thin for their height. And so the independent variables, so the variables that we are testing, the sanitation systems. So these are quite important, and we would like to emphasize that we are focusing on the quality of the sanitation, and that is why we are considering two different types of sanitation qualities. One is, as Sir said, private toilet access and shared toilet access. Now, what is private toilet? So here is the definition. So private toilet, so basically the percentage of population that is using improved, not shared facility with with flush or pour flush to pipe sewer system, septic tank or pit latrine. And shared toilet, the definition of shared toilet is the same. The only difference is that there are two or more households that are using the same sanitation facility. Now here you would see that we are using a pour flush to pipe sewer system, septic tank or pit latrine. Due to data unavailability, we are not able to separate these three different types of sanitation facilities. So we are using this combined measure as our measure of sanitation. Further, we also check another variable that we use for as an independent variable is the percentage of population that is defecating in the open. That is, they have no facility, they're using open spaces or pit latrine. Apart from that, other variables, as mentioned by Sir, that we are also testing unimproved sources of drinking water, micronutrient intake, which includes iron-rich foods and vitamin A-rich foods consumed by children in the last 24 hours. Then exclusive breastfeeding, and as into which is measured by net state domestic product. Now this is the now again we're also checking the effect of sanitation on child mortality, effect of sanitation on child mortality through malnutrition. So again, our dependent variable is child mortality. Child mortality is the number of deaths of children under the age of 5 years per 1,000 live births. And the independent variables would be female education, stunted children, underweight children, etc. Okay, so the method that we're using is a first difference estimation of a two-period panel data. So the hypothesis is that child malnutrition is a function of open defecation, shared toilet, and private toilet access. Now, the implicit assumption in the literature is that the existence of toilets automatically leads to elimination of open defecation. However, that is not necessary. So we're basically testing that. So we are saying that it's not necessary that availability of toilets actually, leads to elimination of open defecation. That depends on the quality of toilets and people's attitude towards cleanliness and the maintenance of these toilets. So we are specifically testing for this hypothesis that open defecation is a function of private toilet access and shared toilet access. SS means a sanitation and sewage system. So thus the availability of private toilet and shared toilet is hypothesized to have both a direct effect on child stunting and underweight and an indirect effect through open defecation. Now here are our equations that we have considered for our model. So first one is basically a linear form of this functional form that we've written. Child malnutrition is a function of open defecation, private toilet, and shared toilet. Here the term summation SI is capturing the state fixed effects, variables that are time invariant. For example, people's attitude towards cleanliness, the geographical features of a state. These do not change over a period of time, at least not over. They are assumed to be constant over the five period of time. So the gap between our two surveys, NFHS 4 and NFHS 5. Second one is the OD equation. The OD is open defecation, is a function of private toilet, shared toilet, and again the error term. We do the first differencing of these equations based on our 2 years, 2015-16 and 2019-21. So these are our first difference equations, equation number 1 and equation number 2. Now, where here it's written that VI is delta UI and EI is change in the delta EOD. EOD is the error term. Now, what we are doing here is that we are substituting equation number 2 into equation number 1. So basically, as mentioned, we are checking the effect of private toilet on malnutrition through or via open defecation. So that is what equation number 3 is. We're substituting equation number 2 into equation number 1 and we're getting equation number 3. So delta y is function of error term, private toilet, shared toilet, where this delta EOD is actually capturing the effect of open defecation. Okay. This one is so now there's this paper Chakrabarti and et al. Which came in 2024, which finds that the presence of toilets or an increased sanitation coverage through construction of private toilets reduces child mortality. So this was testing the effect of Swachh Bharat mission, pre and post effect. So and it says that sanitation coverage through construction of private toilets actually leads to reduction of child mortality, and that is also what we are testing in a hypothesis, in addition to the effect of female education on child mortality. So here is our equation number 4. Child mortality is a function of female education. So the number of females who have at least 10 years of, the proportion of females who have at least 10 years of schooling, and then malnutrition, which is measured by the percentage of stunted children and underweight children. Again, equation number 4 is for difference, first difference, and what we get is equation number 5. Delta child mortality is female education plus delta child malnutrition. Okay. Now here are the results that we have. So if you see equation number 2 here, so equation number 2 is measuring the effect of private toilet and shared toilet on open defecation. So what we find is that private toilets are a highly significant determinant of open defecation. So if you see the last column, equation number 2, so you see that a 1% increase in use of private toilets leads to a 0.84% decrease in open defecation. And if we compare equation number 1 and 3, so the equation number 1 and 3, if you remember, so here equation number 1 and equation number 3 is where we are capturing the effect of private toilet via open defecation on malnutrition, stunting and underweight. So equation number 1, so here what we see is that if you compare equation number 1 and 3, private toilet SS is significant when its effect on OD is considered. So if you see equation number 1, private toilet SS is found to be insignificant. However, if you look at equation number 3, private toilet SS is found to be significant. Now, why is this happening? Is that because open defecation and private toilet, they are correlated, as we see from equation number 2. So that is why in equation number 1, when we are including both private toilet and open defecation, private toilet is coming out to be insignificant. So we're measuring the effect of private toilet indirectly via open defecation. And that is why we have a final model, which is equation number 3, our base model, where we find private toilet is significant, shared toilet is also significant, and open defecation is also significant, which is being captured by EOD. So shared toilet SS is a significant determinant of both underweight and stunted children. Open def and the usual result, which has been seen in the literature, that open defecation increases stunting in children. In our case, it is by 0.15%, and underweight children, proportion of underweight children increases by 0.18% due to increase in open defecation by 1%. Now, apart from the other variables that we tested, unimproved drinking water, vitamin A rich foods, iron rich foods, exclusive breastfeeding for 0 to 23 months, and complementary food intake by children in the age group of 6 to 23 months. These were found to be insignificant in our model when these were tested additionally, apart from a base model, which was equation number 3. This slide shows us the effect of malnutrition on mortality. Now, as I mentioned, public education is very important, and we believe that females play a critical role in imparting that education. So when females are educated, they are able to take care of their children. So even not just mothers themselves, but also females in the family. So if they are well educated, the child is taken well care of. So female education is a significant determinant of child mortality in our example. So you can see across all the versions of our model, female education, 1% increase in female education more than proportionately reduces child mortality. So female education is clearly very significant. Next, both stunted and underweight children. So if you see the column number 1, stunted children, that is found to be significant at 5%. And if you look at column number 2, underweight children is also found to be significant at 5%. So both stunted and underweight children are more vulnerable to. Now the idea here is that both stunted and underweight children are more vulnerable to poverty. So we are not saying that because some child is stunted or underweight, that child will, that child will incur a child mortality. But the idea is that someone who is malnutrition, they are more susceptible to life-threatening diseases. And that is why a child who is malnutrition, there are more chances of that person, you know, being more prone to child mortality, especially because of the EED factor, environmental enteric dysfunction, which can affect their guts absorption capacity. Okay. So stunting has a significant effect on child mortality, and the effect, a 1% increase in stunting leads to a greater increase in child mortality compared to underweight children. And additionally, private toilet SS and shared toilet SS, which they affect child mortality through child malnutrition. So if you look at equation column number 3 and column number 4, private toilet SS and shared toilet SS are found to be insignificant. So that means they're not directly affecting child mortality, but private toilet SS and shared toilet SS are affecting child mortality through child malnutrition. So you can see underweight and standard children, they are significant. So the sanitation is affecting child mortality via the malnutrition, via malnutrition. Additionally, we also test for other variables such as vitamin A rich foods, iron rich foods, basic vaccination, the number of Anganwadi workers, what role they have to play, then diarrhea. So since the data on severe diarrhea was not available, this diet that we're using is a mild diarrhea. So this doesn't seem to have any effect on child mortality.
Well, it's done very well on the time. So let me take over at this point. Maybe go. So back previous one. So what we did here was using the equations we had estimated, we simulated the effect of, we mentioned earlier in the talk that the difficulty was in precisely measuring the quality of maintenance of toilets, etc., which all have effect. So what we did was we picked these two high quality, relatively higher quality sewage and sanitation systems, and then there is an other category, right, which is left over. So what we did was we simulated the effect of replacing the other means of sanitation and sewage, which are less efficient, less quality. Half of that are replaced by proportionately by shared toilets and private toilets. And this the table on the right gives you the effect of doing this. So what does it show? I'll just highlight the yellow portion. So in terms of population, you can see that given this change, which you can think of as what will happen over the future as more and more private toilets and shared toilets are constructed, the change in sanitation, roughly 1 million, I've forgotten the exact, roughly 1 million cases of child stunting will be reduced by this. The reduction in underweight would be about 1.16 million, and the change in wasting would be about 1.2 million. So massive benefits on all types of child malnutrition, whether it's stunting, underweight, wasting, by these methods. And then if you come below to mortality, the effect of all this on child mortality would be the saving of roughly 6.5 lakh children. And Similarly, well, there are two different estimates which are between 6 and 8. So these, I think I've forgotten the change, but so those were the two estimates, but these are still very large numbers, 0.8 million.
Stunting and this was the female education.
Yeah, sorry. So the first one is the effect of, yeah, thanks, for effect on stunting, and the second is the effect of child, of female.
If stunting is
Stunting on,
if stunting is reduced,
yeah,
sanitation is improved, then what is the effect on child mortality? And if female education is improved, then what is the effect on child mortality?
right. If you include both, it is this. Right, right. So the additional effect, yeah, the second one, lower one, gives you the additional effect of female education, and from that we also derive an elasticity of the effect of female education on mortality of 1.07. Next. Okay, so with that, so clearly, with two slides on the conclusion, sanitation and sewage systems are classic public goods essential for public health. That's a broader message I want to leave here. Public health issues like clean drinking water, sewage sanitation, solid waste collection, and recycling received little attention till TSC 2002. So it's very, very important for all of us, including the medical profession, to recognize how important public health issues are. I think the medical profession seems to focus more on individual issues rather than public health issues. And finally, the Swachh Bharat Mission 2014 was a bold move to boost sanitation coverage and eliminate open defecation. Next. So to conclude, the Swachh Bharat Mission, SBM, with its large increase in public and private toilets, has had a significant effect in reducing prevalence of underweight, stunted, and in reducing child mortality. Simulations suggest, as I gave you earlier, replacement of remaining lower quality toilets by toilets connected to sewage systems of higher quality disposal system can reduce the percentage of stunted children by 7.8%. This translated into percentages, underweight by 8.6%, and child mortality by 4.8%. With toilets continuing to be constructed under Swachh Bharat program during FY 24 to 24, universal access to toilet will be attained soon. So attention of public health policy should shift to improving the sewage collection treatment systems in urban, semi-urban, and semi-rural areas of each state. And given our booming upper middle income country in 5 to 7 years, we are aiming to become, and a high income country in 25 years, we need to develop state level grids for collecting, processing, and recycling sewage and solid waste. In addition to that, as we said, the whole issue of public health education and female education has been known to produce all kinds of good things, but adding a public health component to our basic education system would also contribute greatly to reducing child malnutrition and mortality. Thank you. So with that, you can remove that. So we can now turn to our discussant, Dr. Saab.
Okay, so thank you very much for sharing this important paper and highlighting the importance of water sanitation and sewage. So just a bit background regarding this malnutrition, which, so I think we all know malnutrition is quite high in our country as per NFHS 5 also. So approximately 0.5% of our under 5 children, they are severely malnourished, and approximately 18% of them, they have wasting. And all types of malnutrition we have, stunting, they are underweight and they are wasted. These all forms of malnutrition, they potentially increase risk of mortality. But at the same time, there are so many factors which are responsible for onset of malnutrition. So for optimal growth, these children, they need food, but at the same time, there is importance of hygiene, their sanitation, hygiene, water quality, all these factors are important. And particularly, this is the more important for malnourished children. And why? Because these malnourished children, they have lower immunity, and when their immunity is low, they are more predisposed to infection. And for malnourished children, when they are exposed to poor sanitation, hygiene, then there is a vicious cycle, because there will be more episodes of illness, and each episode of illness will be taking longer duration. That will cause poor appetite, and thus there is a vicious cycle which goes on. And there is further compromise in the nutritional status. And we also understand in India, we have a bit slightly different type of malnutrition. And it's very important, this study highlights importance of enteropathy. And this is one of the factor probably that is very important, because in India, what malnutrition we do see, we have a different pattern as compared to African countries. While our African countries, we have very high mortality. In India, we do not see, but at the same time, with the interventions, the other countries, they respond faster, but India usually takes longer duration. And one of the hypotheses is that probably they are not responding in similar way. Why? Because they have enteropathy. So just to highlight enteropathy, importance of preventing and treating enteropathy is that whatever nutrient we all are taking, that is absorbed through our intestine. And there are villi where these absorption will be taking place. And if there is enteropathy, then we will not have optimal absorption. So that is one of the factors why these babies are not responding, and they usually take longer time in improving with the intervention, whatever nutritional intervention which we have. Coming back to paper, I think several points are well taken, and there are important key messages coming from this, particularly regarding the importance of female education, which is reducing malnutrition, particularly stunting, then the improving sanitation, hygiene. We know if they have improved sanitation, hygiene, use of private toilet, then naturally the exposure will be less, and then they will have less infection, then there will be less compromise in nutritional status. However, there are a few points which is really difficult at this point of time to understand. So see the analysis, the most of time the onset of malnutrition is between 6 months to 18 months in our country. And one of the important factors which has been reported is poor quality of complementary feeding. However, in this study, it was reported that complementary feeding and food quality was not found to be significant. So this is something which is not going well with the current understanding. Rest of the things are fine, and I think they are key importance. And if we discuss about the management which we have in our country, as you must be aware, there are more than 1,000 nutritional rehabilitation centers where these malnourished children, they are being managed. And there are 2023 October, the WCD department also published a community-based management of children with malnutrition. sanitation, and where there are 10 steps, which includes food items, nutritional supplements, certain medications. However, one of the important step also is education of the parents and improving child caring practices and improving sanitation hygiene. So that is core component is also there in our community-based management of. So, however, there are challenges in implementation. Many times the Anganwadi worker or frontline worker, they are not able to transfer these key messages to the beneficiaries. So that challenge is definitely there. However, the importance of these component are already, and it's already integrated in the management. So I think with these few words, I think I will stop here, and I will open it for questions or comments by other people. Thank you.
Yeah. So, right. So I will just make two observations before we open it for questions. Actually, we kept to our time very strongly. That's why I'm going to make a few more comments. Surprising, I think. So one comment, a little bit of history of EED, I think, is important for understanding. What happened was, it's actually since almost as early as 1960, they found when the foreigners came to kind of less developed countries where sanitation was poor, whether it was South Asia, Africa, where the records were there, they found that foreigners got this problem of EED. It was called something else earlier. Entropy, but tropical enteropathy. So when people from the cold countries came to the tropics, they developed this problem, and it was there as long as they were in the tropics. When they went back, after a while, it seemed to go away. However, citizens of these countries, whether it was South Asia or Africa, who went from these conditions to the cold climates, continued to have these problems. Okay, so what Professor Praveen Kumar said is true in a way, but it's slightly different way from my understanding. That it is long lasting. It gets into your guts. It can't just be removed. There is no till now they've not discovered the disease of EED. It's a phenomena or a condition. So they've not been able to find a disease which they could cure, but it does seem to have lasting effects once you get into it very deeply, right? So that is the history. The history of this thing shows you that. Okay, I'm not talking about econometrics. And so eventually, and this took a long time for them to recognize, they thought there is something to do with the tropics, it's a heat, it's other diseases, it's diarrhea. They investigated all these things medically, but they couldn't find a specific disease or a set of diseases which resulted in this phenomena. So they came to the conclusion and defined what is called EED now. When was it? Roughly 2010s or something like that, right? Or 2000? Yeah.
2000.
Yeah, around 2000, middle 2010s, roughly. Yeah. So that is the phenomena. Okay, and it's not identified. You can't change it. Okay, so that's the first point, and it's lasting. Just by removing it, you don't immediately get the effect. Okay, but you do see an improvement. Now, and you see the improvement in the child, because then if a child is raised in a better quality environment from the sewage and sanitation perspective, they will not get EED, and therefore they will not be show this phenomena. So, so if you see a population, just imagine in a village of 100 people, there'll be 1 or 2 children born, they will be better, right? But to see it in a aggregate sense, it will take time. So the second point I want to make is that they have now been very carefully done RCT studies. We have mentioned them. I didn't go into the big details by Muralitharan and other people, where they have given, tried the usual things directly. They have given food supplements, nutrition supplements, etc. And one of the conclusions they came to was that that in situations of bad sanitation, they have no effect, which is what kind of what we are saying. We are not saying in this paper that it never have any effect. What we are kind of, we go with these RCT studies and in sense, kind of not prove them, but support the same conclusions that this is a primary issue. Other things will come later. So once you have a very good sanitation system, that doesn't mean malnutrition will disappear. There will be other issues, but what the point I conclude, people may disagree with me, but I conclude that this is kind of a prior. You have to do this if you want to make a big impact on what is defined as child malnutrition in terms of stunting, etc., etc. Again, I repeat, our results don't say that all these kind of, whether it's breastfeeding, we know breastfeeding is important because again, if the EED occurs through some things in the environment, the moment you start having water or supplementary food, that can get in. However, if you're breastfeeding, the chances of getting in are less. So logically, even if we believe in EED, breastfeeding should help. We just said that it does not explain the interstate differences in stunting, etc. So unfortunately, even we did not replicate the RCT findings that in areas where the so-called the private toilets are there, that nutrition should have a bigger impact. All these nutrition were. We expected it, but couldn't find it. And the explanation I would give is that we are not able to measure the quality of the sanitation. We are just measuring the private toilet or shared toilet. But what is the system of disposal? Where is that sewage going? So if you have two conditions where in one case all that sewage is perfectly disposed versus eventually it goes back into the environment, then in the second situation you should not get any effect, any positive effect, right? So, but with the data available in NFHS, one is not able to go into these type of quality issues. So that's how one would explain this effect. Do you want to add anything? And otherwise we'll open it to questions.
Yeah, so they were saying about nutrition. So we're not saying that nutrition is not important. Also, the nutrition that we mentioned, it's basically we're looking at iron-rich foods and vitamin A-rich food supplements that we were given to these children in the last 24 hours.
24
in the last 24 hours.
Hours, right.
Yeah, so the last 24 hours. So we're not basically saying that nutrition doesn't have any effect at all. But obviously, sanitation, as sir said, that has a very important role. So until unless sanitation, the issue of sanitation is resolved, the proper system of sewage disposal, then until that, nutrition and other aspects will have
small effects.
Small effects. So the effect of sanitation is much more on malnutrition than these. The limited variables that we have for nutrition.
Okay. Okay, so we are doing very good on time, so we have lots of time for questions. So please go ahead, open up for questions.
Yeah, so I just wanted to add one point here, and before we can take questions. So I think, sir, current understanding and the people are trying to understand regarding this enteropathies, the looking for change in microbiota, and probably that is different in different population, and that is what the people are trying. And the children who are severely malnourished, they have a different type of microbiota, and there are a few trials where they are trying to see whether there is any change of this microbiota is going to help. So regarding the interventions, I think the interventions should focus all these components, and the component which will include sanitation, hygiene, toilet and everything. And all these are known as essential nutritional practices. And we all should go for essential nutritional practices, where there should be importance on exclusive breastfeeding, timely introduction of complementary feeding, dietary diversity, poor sanitation, hygiene, no, all those components should be highlighted. Over. Thank you.
Okay, thank you. So again, I don't think there's any disagreement, but I think there is still underemphasis on public health education. And so this is something which I would again urge those who are involved in this whole thing. So public education, health education can work through the children, through parents, both female and male. Of course, as we have shown, the female education has more direct effect on malnutrition, I mean in mortality specifically. But I think just the knowledge, the understanding, if it's imparted to the population, is in a way more effective and more cost-effective means of achieving results, because you also want sustainability. Because one of the issue which arises is the issue of maintenance is often there, whether it's a private facility or whether it's a sewage system. I've been traveling over many parts of the country in the last 2 years, and what I see is the difficulty or the challenge of maintaining any system, whether it's a drainage system or a sewage system or sanitation system. So educating the public from child, from school, both the male child and the female child, in this whole issue, I think can give much more benefits than anybody kind of imagines, and that's a lacuna. That's all. We are just trying to emphasize things which we feel are underemphasized and not given enough importance.
Compared to
Okay,
nutrition.
right. Okay. So nutrition program, for example, by the way, I've been in public service for 50 years. I've seen these programs for 50 years. And one then wonders why are they not effective? So we also actually need to investigate more carefully which part of these programs are actually producing results and which parts are not. I don't think we have that evidence yet, and hopefully those of you who are studying, you should do these, get involved in a little bit of research like this and investigation. I think it'll be good for the country. Okay. So questions? And if it is for Dr. Kumar, please mention that the question is for him. Ratanji? Dr. Ratan?
Yes,
questions
yes,
are-
sir. I have an observation of the
हाँ जी,
total
बोलिए,
under 5 deaths.
Right,
Of the
right,
total under 5 deaths,
right.
90% take place in the first year, and of
Mhm.
these, 70% take place in the first month.
I see.
So
Okay.
this is an observation. Most of the deaths, they are taking place either in the first month or in the first year.
So would you say that is related to mother's health, mother's issues, or what kind of, I mean,
So this is, I think, Dr. Praveen Kumar, if you can throw some
Yeah.
light.
okay, right. Dr. Praveen
Can you-
can answer.
Yeah. Can you just repeat questions, sir, please?
Yeah, this is observation,
Uh.
out of the total under 5 deaths,
Yeah.
around 90% take place in the first year.
Right.
Infant mortality rate is, you can say 90% of the under 5 deaths.
Right.
And 70% neonatal mortality, out of the total infant mortality.
Right.
So
So,
what could be
sir,
the reason for this?
Yeah. So maximum death is happening within first week of life, and then the neonatal deaths contribute approximately 2/3. So you are very right as per our own data, and one of the reason is high prevalence of low birth weight, which approximately 18% of our delivery we have birth weight of less than 2.5 kg. which is one of the major contributor. When they are low birth weight, they are high risk of no sepsis. And then the other important contributor are birth asphyxia, because still the prenatal care and identifying high risk deliveries is not happening. And with time, this has definitely decreased, and there is a progressive decline in these mortality, but still we have high. So for improving this, we need to identify, improve maternal nutritional status, identify maternal illnesses before they are becoming pregnant. So there is a need of preconception care, and then improving antenatal care. That is what is needed.
Absolutely.
Thank you.
Absolutely, I agree. Yeah. अच्छा, और other questions?
ऑफिसर हमको मिलेगा, क्लास 1 ऑफिसर हम डिजर्व करके मेहनत की हमको डिजर्व करते हैं, क्यों ना कहते इतना लेट आपको कह रहे हाँ.
Dr. Ratan Chand, I hope you're controlling the questions somehow from there, because I have no idea.
Yes, sir. Question, I don't see many question here.
Okay.
In the chat, I think there are some
In the
questions.
One
chat,
question is from Anandu. He's saying
Ah.
female, I think empowerment is important for access to better health. I think that is the
Yeah, we are-
observation, not a question.
yeah, we agree. Yeah.
Sir, may I pose my question? If
Yeah.
you kindly say, sir, Professor Ratan Chand, can I
Yes,
please?
please. Yes. Yes, go ahead.
Sir, infant mortality rate has steadily declined from over 30s to 27 right now. So what is happening means you have showed from NFHS 4, which is round about a survey means used in 2015-16 to till now NFHS 5. Now, when studies were means UN has emphasized WASH activities, that is water, sanitation and health in girl child education long back, and that has means it has been shown continuously over the world that it influences education. However, in India, there are other barriers too. Census data shows clearly open drainage systems are huge, that is around about 84%. And also this census 2011, and also though the means female education means increases, but still it has been shown that female infrastructure are used in different other purposes, which is affecting upper girls enrollment directly. Also the endowment, so this is becoming a cyclical function, as you see. So that is why I was thinking whether this endowment part to access better health, it remains important, and basically it's a cyclical function, what you mean, which has been put to one point.
Yeah, I mean, the point about toilets being used for other purposes, of course, is a very relevant issue. And as I think Shruti mentioned, that in some ways, when we are doing an econometric study, the issue there is quality, which includes both the usage thing, which, as you say, may depend on various factors, and on how you dispose the sewage, etc. So yes, I mean that's true. Yeah.
And he was talking about
Yeah.
open drainage systems, because we are saying that improved quality is what is going to reduce child stunting and child underweight. That is why we were specifically talking about the pipe and post flush system. So open drainage system is obviously a problem, and we are also talking about the proper disposal through pipe sewer systems as an important determinant of child malnutrition.
Right. So looking forward into the future, as we said that, and I hope more people recognize what you are saying. I agree, which will put hopefully public pressure on urban authorities to have better sewage systems, etc. Because as you know, health and these things are constitutionally the responsibility of the state, and awareness of the public living in each of these states, which is why, if you recall, I showed you the interstate table, so there are different differences among states in the number of toilets and of course the quality of the sewage systems, which we are not able to directly measure. But yes, all the points you made are very relevant. Anybody else?
So mostly these are observations, I think.
Right.
If anybody has any specific question, they may raise their hand and ask.
Yeah, okay. Why don't you? There was some point Shruti wants to add.
And then we discuss the harm, but if the quality of the water is poor,
Yeah,
then-
right. So, okay, that's good. We have been very quick. I think because Dr. Charan Singh was very particular about timing, we kind of under. आया कुछ और question आ रहा है, कुछ आ रहा है?
This is the question is the children of migrating laborers, poor vendors in Gandhinagar, Ahmedabad, Gujarat, feed up themselves through begging on. These are general questions. I don't know.
Not related to our topic, huh? Yeah.
Yes, yes.
Okay.
So, if Professor Bishandas, you have any observation? Mute
Okay.
है आप mute, unmute कर लीजिए.
Oh, Professor, I didn't see you. Otherwise, I would have called you.
Thank you, sir. It was a very encouraging and very rich in discussion. Thank you very much.
Thank you. Okay, so yeah, so I'll hand over to you and Dr. Ratan to conclude.
So, sir, I have few announcements. In the next week we have 3 webinars starting from November 3 to November 7. So on November 3, there will be a webinar on Chapter 3 of IMF publication, that is Regional Economic Outlook, and the topic will be Reshaping Value Chains. So that is for the November 3. And November 4, again from the same publication, Regional Economic Outlook, Chapter 4. This relates to investment efficiency and capital allocation. Then on November 7, it will be on a book written by Professor Arvind Gupta and Rajesh Singh. And it will be, the book has been published in July 2025. And the topic is Silent Enemy. So these are the 3 webinars we will be announcing on our website, and also will be informing the all the participants, those who are in our mail list. So that's the, and at the end, let me thank the chairperson, speaker, and the discussant, along with all the participants who have taken active part here in this webinars. So thank you very much. And I think Professor Charan was also saying he will join, but I'm not seeing his name here. Thank you all. Thank you, Professor Ashok Bishandas. Thank you very much.
Thank you.
So with this